Okay, any questions before we start? All right. Assignment 2. So I graded assignment 2. I've got bad news, good news, and good news. So bad news is that it was clear is that these last three, the three questions 3, 4, and 5 were hard. So not very many people got them. So just to show you, I put the sorry, I'm having allergy issues. But I put the assignment, the answer sheet online so you can see it. Most people got this one, where it was like, what happens if it's $200? So you got that. Then when it came to this one, what happens if it's a 20% copayment? What a lot of people did is that they kind of sort of calculated the premiums based upon 20%, not 80% of the total. So, and then for this one here, for deductible, some people added in the 500 on top of the 400. But remember, what a deductible does is that, or what a copayment does is it basically takes off some money that the insurance company has to pay. And so therefore, you always calculate the premiums, the fair premium, based upon what the insurance company has to pay. So the whole kind of logic behind doing these is to go through and to try and figure out what's the insurance company have to pay, and because that's how you figure out your premiums. So some people went and did 20% rather than 80%. And then on this one, sometimes people thought, well, they're $500 deductible, so therefore this person owes negative $100, and that which is logical, but the way that the deductibles work is that basically if you only have a $400 charge, then you pay the entire 400, and the insurance company doesn't give you the extra 100 back. You just don't pay it. So that was one thing, but then other people added in the 500 on top of this. So just remember that with deductibles and with co-insurance is that the idea is that the person pays some additional money out of, for when they have a loss. And so whatever is left over, that's what the insurance company pays. And then the fair premium is based upon that. So the good news, first good news, is that, well, most people didn't get these ones. And so the average score in that on this was about maybe 6 or 7 points. So well, if you got 6 or 7, then you probably did about as well as the rest of the class. And then we'll go through and we'll, when we do the final grades, we do it on a curve, so it's not gonna kill your grade. Second thing is that this will be the last time that you see this type of math problem. You're supposed to go, oh, try it again. This is the last time you're going to see this type of math problem. So because I won't ask you this type of thing on the test, and we won't have other types of questions that are this math involved. Wanted to do it because it's a fundamental thing about insurance, and so kind of to understand how insurance works, but this will be the last thing you see. Any questions about assignment 2? Assignment 3, I have someone pointed out that there is no Anthem Blue Cross EPO for Newport Beach. And I realized that I wrote EPO rather than HMO. So I've changed assignment 3 to look like someplace here. There, so I changed assignment 3. So now all these things say HMOs, except for down here on question number 5, it still is an EPO because up in Eureka, it's an EPO. Down in Newport Beach, it's an HMO. So same basic thing. So, but everything else should be the same. But I extended the deadline until the 17th on turning in the assignment. So, but I did, and one other thing is that for some reason, for some people, when they click on this link here, is that it goes directly to the, it goes to a kind of a different page than I see. It's the same page, but a different tab. So what you have to do is that when you get to that page, if you don't see the little box that says Explore Plans, look for the little tab that says how to get covered. And you have to click on that. And then it will, once you click on the little how to get covered tab, then you'll see the Explore tab. So I'll show you what I mean. Here, I'll do it. So this is what I see, right? And there's the Explore plan. Some people show up on this page. What is covered California? And notice there's no little Explore plan thing here. So you have to come up here and sort of do the how to get covered. And then once you do that, then it will take you through everything. Any questions about assignment 3? Okay. For the someplace here. For the midterm, so the midterm is next Thursday. So I put a bunch of materials online for you to study. So what I've done is I kind of just consolidated the history slides, and I've consolidated the other slides, the lecture concept slides. So it's the same basic slides that you've seen, except for I kind of cleaned them up a little bit. But and just put them all in one place. So you have all the slides here. And then I did a little kind of a short thing, basically how to study for the midterm. So it shows like type of questions and remind you that there are 35 multiple choice questions and things like that. And then also I have the terms for the study terms. So study terms look like this, right? Where you have, I've broken them down into terms from the history lectures, terms from the just the structure about, this is sort of the review about the healthcare system, and then this is the concepts. And the concepts are things like adverse selection, things like that. So I've broken the terms up with that. There's no real terms. I mean, there's not from the readings. I'm not going to ask you anything from the readings. I've given you some readings, but they're mostly just background type of readings for you at this point. So I won't ask you anything about those on the midterm. Just to remind you, in terms of the midterm, whoops, where'd it go? Is that it's an in-class exam, so no online exam. You can bring a one-page sheet where you can write whatever you want on front and back. You don't have to, no calculators, so there's no math on the test. And then just bring in a pencil or pen. Do you have a question?
Oh, have you put the study guide or?
Yeah, so that's what all this is. So this thing here, that's basically the terms. So, and then these are the, yeah. Any other questions about the midterm? Well, this is how to study for the midterm thing that I put on there. So it just shows you the types of questions. No Scantron. Just pencil pen. I'll give you a packet of the tests, and the test will be like 5 pages, and you just go through and circle the answer, then give it back to me, and that's it. Yeah. In any way you want. You can type it, you can write it, you can do whatever you want. Front and back. Mm-hmm. Yeah, I mean, the reason why I think it's helpful to go through and to do a one-page sheet is because one is then you don't have to memorize things, which is always kind of nice. But the other thing is that hopefully what it does is it forces you to go through and to organize the lectures, because I actually do try to have some type of organization through the lectures. And so the way I would study for it is I would just focus on the lecture notes as if the lecture notes were a book, and then go through and just to start summarizing, like making bullet points out of what the lecture notes kind of said. I won't ask you details about things like, I don't know, how many times was the Obama, was the Affordable Care Act, how many times did it go through the Senate, something like that. Some of the details that's in the slides, I'm not going to ask you about that. So it's going to be more bigger picture type stuff. Okay, we're good on the, yeah. Yeah. Mm-hmm. Yeah, 35 multiple choice. Some of the multiple choice are hard, so I try to make some easy and some hard. So when you're taking the test, just remember that, give it your best guess. What I do is at the end of the exam is I'll go through all the answers and I'll look to see kind of which ones people got wrong. Because sometimes I think the answer is A, and 80% of people say B. And I go and I read the question, I realize that, yeah, I can kind of see how you could say B. So what I do in that case, I give you credit for, I give both A and B credit for right. So, those are the type of things where that's why it's worth it, your time, just to give it your best shot. And also is that, since I'm the one grading them, is if you think that if you're interpreting the question a certain way and it seems confusing, you can actually just write on the test. This seems confusing to me and I'm interpreting it this way. And I'll take that into consideration too. Yeah.
Our exam is next week on Thursday.
Yep. And so if you need extra time, we won't have extra time in here because someone comes in right after us. So if you need extra time, go talk to the student services and set it up with them. I haven't received anything so far. So usually I receive a notice that says if somebody needs extra time and I have to send them the exam. So I haven't received anything. So if you are going to do it, then probably should jump on and get it done. Any other questions? Okay. So this week is sort of drawing the close, the last of the history and concepts and things like that. So if I kind of reflect on, well, what is it that this class is actually doing? What is it that I'd like you to walk out of this class with? One is just to understand kind of what our healthcare system is like, right? And why it is that we have this type of healthcare system. So the reason I go through all the history like that is because it's really the only way to understand, the only way I can, at least to me, that I can understand why it is that we have all this, everything's so entrenched in these sort of different type of ways of getting healthcare, and why it's so difficult to change. Also, why it's such a big deal that Affordable Care Act, was passed, because it was, 100 years of people trying to get some type of universal coverage. And even though the Affordable Care Act is not a perfect plan, it's pretty good in terms of giving people coverage. So that's part of the reason I do it. It's just so you can understand things. And as part of that, then it's also to kind of give you some of the basic concepts like, why is adverse selection such an important thing in healthcare? And the other kind of questions that we've gone through about, why is it so hard to go through and to identify, the sort of the package of benefits that people should get, things like that. So there's that aspect. But the other aspect is to kind of give you a heads up for things that if you go and get jobs in healthcare that you're going to run across. So, there's a number of different things, like if you get jobs in public health, or if you get jobs out with one of the healthcare providers, or wherever you're going to go after this in health, is that there are things that you're going to hit where you're going to think, what is that? So that's kind of the other thing I'm trying to do, is to give you some type of heads up about what it is that, that you're likely to see out there. So today, we're going to talk about quality of care, integration of care, coordination of care, things that, I mean, personally, I don't really have much experience with quality of care, but it's one of the three main pillars of in my research area, or in my area of public health. Now, the area of public health, I'm in health services research, and the three areas are basically, cost, expenditure, efficiency of the healthcare system, access to care. So that's where all the insurance stuff comes in. And then the third is quality. So if you go on to graduate school in public health, is that, you can go to graduate school and just study quality of care. And so quality of care is something for which it's one of the important things. The reason that I don't talk about that much is because, as I'll describe, quality of care tends to be something which is done, a lot of it's done by clinicians, clinicians to clinicians, as opposed to people from the outside kind of coming in and trying to impose quality in healthcare organizations. Okay, so I think a couple weeks ago when we started this, I talked about the concept of an episode of care. So the idea is the episode of care is, what happens from the time that you start some type of health incident to the time that it's concluded. So that health incident could be, I think I used the example of getting hit by a bus out here and breaking my leg. And so the episode of care starts when the ambulance comes, takes me to Mercy, gets a cast on, gets an MRI, sends me off, sends me home. I go over to to Golden Valley, and get checked up. I come back to the hospital for a specialist, and then they cut my cast off, and I'm either fine or I've got some limp. But whatever it is, at that point, the episode of care ends. So, you want to think about the episode of care then is basically all the different types of things that happen to someone given some type of health condition. Now, you can have an acute episode of care, and you can have chronic episodes of care, and you can have acute episodes of care within a chronic condition. So, for example, like diabetes, chronic condition. Chronic condition means what? What's the difference between acute and chronic condition? Yeah. Yeah, it's about 6 months. So anything that lasts more than 6 months is a chronic condition. Anything that has less than that is sort of seen as an acute condition. I mean, it's kind of an artificial type of designation, but really chronic conditions are diabetes, heart disease, asthma, there's like 6 and 7 main chronic conditions. So you can have diabetes, and that with diabetes, then you have a certain type of care you should be receiving, a certain way you should do diet and exercise and everything. And then if you have an episode where your diabetes gets out of control, you might end up in a hospital. And so then you have a hospitalization. But then once you're sort of stabilized again, then you go back to the same way, to being managed like the chronic condition. So that's a case where you have, a chronic condition episode of care. And then you have an acute phase, then you have the chronic condition again. Then you can have a chronic condition like diabetes and have a heart attack, right? Where you have something else happen. So there can be lots of different episodes of care that kind of overlap each other. But what distinguishes them is that there's kind of a type of treatment that you should be doing for the episode of care. And that's what the focus of this is. It's like, what's the treatment you should get for the episode of care? So we said that there are 2 ways that you could figure this out. So one is that you could look at how people are actually treated. And then just sort of that's their episode of care. But the other way is to look at, clinical guidelines. Because what clinical guidelines should show you is they should show you how ideally people should be treated. Okay, so we talked a little bit about clinical guidelines, I think, last time. I think I gave you this reference to the Mayo Clinic clinical guidelines, not because I think that you're really going to be that interested in the Mayo Clinic's clinical guidelines, but just so you can see what one looks like. So, this is their, non-surgical management of hip and knee osteoarthritis. So it goes through and talks about, this is their, the questions that they're looking at over here. This is how many randomized controlled trials and other types of studies that they found on it. So it talks about how they go through it and how they, went through and got the information, and these are their recommendations for everything. And then it comes down, and it shows you like these little diagrams about how the patient should be treated, what should happen along the way. And clinical guidelines are usually they're pretty voluminous type of publications when it actually comes out. This is just a summary of the clinical guideline. So when it actually is, it's pretty big. And I'm sure all clinical guidelines now for doctors are just it's on their computer system. So when you go into a doctor's office and they're sitting there typing on their computer, they're probably not on ESPN. What they do is that they have their own type of software system within their practice, and most of those software systems, they're linked to clinical guidelines. So if the doctor types in osteoarthritis, hip with osteoarthritis, they can see the clinical guidelines right away if they want. They don't know, they often don't see them, don't want to see them, but they can. So usually clinical guidelines now are embedded in the software systems that that doctors have. And then it goes down and then it sort of summarizes, here we go, keeps going and going and going. And then it summarizes, what it is that you should do. So that's a clinical guideline. All right. So episode of care then, that tells you what happens to the patient. The actual care tells you, if you look at what happens, if you actually track to them, what happened is that's their actual care. And the difference then between the actual care that they get and the clinical guidelines, that's called the quality gap. So the quality gap refers to, the difference between what should have happened to you versus what did happen to you. So to give an example, here's a woman with an ankle injury. So if you're looking to see, and remember last time I also talked about how, clinical guidelines also differ, or the episode of care also differs basically whether, who you are and how much money you have. So if you're someone who has lots of money and great health insurance, is that you might get a different type of episode of care than somebody who, has no health insurance. But what a clinical guideline should show you is that what the recommended, what's the basics that's recommended. So in this case, the ambulance takes the person to the emergency room. So this is what what the clinical guidelines would say, right? Ambulance takes the person to the emergency room, seen immediately and given an X-ray. In reality, they had to be taken there by a friend and they had to wait 12 hours to be seen. So if you look at the difference between those two things, you think, oh, well, that's, the care that she actually received then was not the same as the clinical guidelines. So therefore, that's a problem. Specialist recommends a walking boot, right? Here, the person didn't get an X-ray, but told they're no break and sent home and told to see the GP. So if you can just go through all this, each of these different things that happen here are different than what the person actually had to do. And where there's differences there, that's where you have the quality gap. Okay, so why is quality such a big deal? Well, quality is on a fundamental level. Quality is, we care about quality because, gaps or problems that exist in the healthcare system means that people are suffering. So you never really have issues. There's never a case where they deviate from the clinical guidelines and it's a lot better outcomes. Is that when there's problems with the clinical guidelines, it's problems with people suffer because of it. The other thing that from a practical standpoint, healthcare providers, especially in the U.S., worry about getting sued. And so if you see someone's actual care and you see what they get is different from that, and they have some type of bad outcome, then they can sue. And that's how lawsuits are kind of based, is that they bring these doctors in and they say, what was the care the person was supposed to receive? What actually did they receive? And then they try to make the link between the care that they got versus the injury. And that's the basis of a lawsuit. So hospitals, especially, became very, very focused on this kind of these medical errors back in the 1980s. So, I think this came out here in the lectures that we're giving, or the history of things, where I said in the 1980s, that's where kind of problems started to rise in medicine. So it became a big deal. And so hospitals first tried to deal with it by essentially not talking about it. That is that if a medical error was made, that if a patient had something happen to them and was threatening to sue, they would just kind of, get silent, draw the wagons together, and try not to say anything, and then just fight it in a lawsuit. What they've done since then is they've realized is that, well, oftentimes when someone has something bad that happens to them, what really, the first step should be is to acknowledge that something happened to them. So most hospitals now have kind of changed the way that they deal with this type of medical errors, and that they don't necessarily take this approach that, if it looks like you're going to sue, we're just going to not talk to you. Instead, what they try to do now is they try to sort of work with you and say, well, we're really sorry and things like that, as a way of just sort of acknowledging that people may not want to sue, but they just may want to just have it acknowledged that something bad happened to them. Okay, these things are called medical misadventures. It's a great name. More commonly, though, called adverse events. So oftentimes you'll hear people talk about adverse events in healthcare. And what they mean then is that something that's unintentional that happens to the individual that's results from the healthcare. So, it's not that it's got to be something for which it's the healthcare that was given to someone caused something else. So it's not their underlying condition. So for example, if someone comes in with a heart attack and they're trying to save them and they can't save the person and the person dies, right? That's not a medical misadventure. Because, if they follow the clinical guidelines, then that's not a medical misadventure. It's a bad outcome, but doesn't mean that there's an adverse event. On the other hand, if the person comes in and suffering a heart attack and they give them some type of medication and the medication makes things a lot worse, then that's a medical misadventure. So it's because of something that happens during the treatment that leads to worse outcomes. So the first kind of big study on this was the Harvard Medical Practice Study back in the 1990s, where they went through and they looked at all these different types of medical records, and they had people go through, like clinicians go through all these records and then try to see, was there evidence that something happened to the person? And they found that their rates was like 3.7% of hospital admissions. So on one hand, you think, well, that's not bad, right? But then if you look at kind of what happened, like there's a lot of really bad things that happened from there. And then it turned out that, well, what they were referring to as sort of a medical misadventure, an adverse event, was not something for which something bad happened. It's more that was there negligence. And negligence is not the same thing as an adverse event. So for example, if you go in the hospital and they give you penicillin and they don't know that no one knows that you're allergic to penicillin and that you have a reaction to the penicillin, that's a medical misadventure. It's not a preventable one. So you could have medical misadventures that aren't preventable, but it's still something for which, the treatment caused you some type of ill effect. And then even if it was preventable, right, it can still, not be negligence. So it could be preventable in the sense that, someone could have done something about it, but negligence is a different kind of level of responsibility. So the Harvard study, was really kind of looking at this thing about, well, how much could they actually get sued? But other studies that came along, they kind of went through and that they just looked at what percentage of people who are in the hospital have either there because something happened to them in primary care or have something happen to them when they're in there that extends their stay. That's significant. So it's not just, they didn't treat my bandage fast enough, but something that has some type of significant effect. And they came out with about 16%, 17%. I was involved in one of these studies. They brought me in to kind of do the economic parts of it for one of these studies. And the way that they work is that you get these clinicians and that they actually just go through all these medical records. And then based upon the medical records, because most of these medical records are just, they're just like a file. And so they go through them and they try to see, well, is there some indication that something happened along the way? And that if they find something, then they both have to agree to it. And then they try to figure out, all right, was there some type of significant kind of a negative outcome that occurred? If there was no significant negative outcome, then it's not a medical misadventure. So it's got to be something where the person has suffered in some way. And the study I was in came out about the same, 16, 17%. Most of them were drugs. Like I think, or at least not most of them. The most prevalent type of thing was drug reactions. So they give a drug to someone and the person has a bad reaction. I think that was like 10 to 15% of the total. But the other common ones were like surgeries. It's like I think I mentioned last time, when they do hand surgeries, they oftentimes screw up. So surgeries, orthopedic surgeries especially, have a lot of kind of medical misadventures. So this became like a big deal back in the 1990s when all this came out, that, it sort of shattered this myth that suddenly healthcare was, this doctors were just doing good all the time. And that sort of started to focus a lot more upon how can you improve the quality of care. So there's two basic ways that they try to improve the quality of care. What's called the person approach and the systems approach. So the person approach is what you do is you focus on the individuals who made the mistakes, and that you then either punish the individuals or incentivize them somehow not to make mistakes. And the other way is what's called the systems approach, which is that you sort of take from the you take it from the starting position that the people don't want to make mistakes, and that any errors that occur are because the system was set up. So what industry do you think the systems approach is the one that has proven to be the most effective? What industry do you think is the safest industry in the world? What type of industry is the safest in the world? Yeah. Say it louder. One more time. No. Let's see. Which one is that? I'll give you. It's something for which when mistakes happen. Oops, it's really bad. And so they've been really good at not having mistakes happen.
The one-on-one approach, where like the doctor takes the information of the patient instead of the patient.
No, this has nothing to do with healthcare. It's outside healthcare. What industry is the safe? Well, has anyone gone anywhere recently? Like travel? On a plane? Airlines are the safest. Right? Airlines are the safest industry. And the reason is, I mean, really, if you think of it, there hasn't been a major crash, knock wood, in quite a while, really. And crashes, when they do occur, is that they tend to be, kind of caused by things that are not are very rare and unexpected. Not small planes. A lot of small planes crash. In fact, at one time, I had this idea that I was going to learn how to fly. And so I came home and announced it to my wife. Good news, I'm going to learn how to fly a small plane. And she was not supportive of my decision. And what she started to do is she started to find every day in the news the incidents of small plane crashes. And it turns out there's a lot of small plane crashes every day. And so I was just getting bombarded. She just started in the morning by just sending me these articles of small plane crashes. So that was denied my request to become an airline pilot. Because small planes are still dangerous, but big planes really aren't that dangerous. And one of the big things that they changed in airlines was that they made it so that anyone can report. So if they have a concern, anyone can report it. So, because airlines used to be very hierarchical, where you had the pilot and you had the co-pilots, and then you had the senior flight attendants and you had the flight attendants. So it was a very hierarchical type thing. And what they found is that, lots of times the pilot, the co-pilots didn't want to question the pilot. And so therefore, even when they saw things going wrong, is that, because of the power structure, they didn't say things. And so mistakes happen. So what they tried to do, what they have done, is change the culture so that within a cockpit, anyone can say anything. And that, like anyone can point out a potential problem. And that the idea then is that, the person's not going to get punished for going through and saying it. So if a co-pilot says, are you sure that valve should be like that? And that it's just a stupid thing to say, is that they don't get reprimanded for it or whatever. In fact, there was a crash here at a SFO, San Francisco, a few years ago, when a plane was, I'm not sure if you've ever flown into San Francisco, but you come kind of over the bay and then you land onto the runway. But as you're coming in, you're on the water and you can see the rocks that are there. And then the runway starts basically right where the rocks end. So and this plane landed too soon hit the water and then just sort of washed up on the rocks. And no one was hurt. They got everyone out. But when they started looking at, well, what was the problem here? Well, it turned out that the pilot was an older pilot who was I think it was Korean. I think it was a Korean airline, was ex-military. And so, and just ran the cockpit as if, he was the boss. And so whenever the co-pilots tried to say something, he would just, shout them down so that all the co-pilots just learned not to say anything. And so when they talked to these co-pilots later on and said, did you notice anything was wrong? They said, yeah, we did notice it was wrong, but we know not to say anything. And so that's the type of thing that they're trying to avoid. So that's because what they're trying to do is make it so that no one gets punished for it. The other thing they try to do is they try to make it so that it's essentially as they view all errors as system errors, that there's something wrong with the system. So if you think about in a surgical ward, where they try to, when they are going to do surgery, is that they have the same type of ethos, which is that anyone in the surgical ward, in the surgical room can say something. So, in the surgical room, you have the surgeon, maybe you have an assistant surgeon, you have an anesthetist, you have some nurses. So, there's a team that's in there. And that the rules is that if a nurse sees that, questions why a doctor is doing something, is that they have the right, in fact, they have the responsibility to say something. Even if the doctor gets pissed off at it, is that they have the responsibility to do it. So that's what they're trying to do, is to make it that kind of, that type of culture. The other thing they do is they sort of think, well, how do mistakes occur? And then they try to reduce the mistakes. So one thing that used to happen fairly regularly, disturbingly regularly, is that, somebody would come in for a knee replacement and they would replace the wrong knee. So someone would come in to get their right knee replaced and they would replace the left knee instead because they, misread which knee was the problem. So now what they do is that if you go in to get surgery, they'll come into your room before and they'll have a little sheet and they'll say, okay, you're, Mrs. Johnson, and we're here for your right knee. And then they'll point to your right knee and they'll say, that's the one, right, that we're going to do. And they'll put like a big green mark on that one. And then they'll say, and it's not the left one, right? And they'll put a big red X on your left knee. So what they're trying to do is they're trying to, to anticipate that that's where mistakes can arise and then kind of avoid them. Another thing that they do, a big way that they for medical errors is giving medications. And so one way that hospitals deal with this is that they say only pharmacists can give up medications. Another way is that, if you go in the hospital, they'll give you a little band, right? A little wristband. And on the wristband will be a barcode code. And when they come up to give you your medications, in some places they have to scan your band. And that if your band, because the way medications work in hospitals is that the pharmacy department usually puts together the packages for medications. And so then they send them up to the ward. And so, there's usually a room where you have all the medications there. And so the nurse, when they come in to give the medications, they have to scan, they have to scan this thing. And that says, okay, so we know which one it is. And then what they have to do is they have to go over to the patient and they have to scan the patient. And it's only then that they get either a signal. Sometimes they have boxes that won't open until they're both scanned. And so what they're trying to do is make it so that there's an extra step that goes along. So, do mistakes still happen? Yeah, because, sometimes, people take shortcuts and they try, like that, maybe get 4 different medications at the same time and then try to get 4 different patients. So they take shortcuts. But what they're trying to do then is anticipate where the errors are going to arise, and then you set up the system so that to try and avoid that. You set up safeguards. That's basically a systems approach, where you're not focusing upon trying to threaten people. Instead, what you're trying to do is like all mistakes are viewed as system mistakes. And if a mistake occurs, then you try and set the system up to avoid that mistake. All right. Swiss cheese, that's what it's called. it's called the Swiss cheese model of accident causation, because, the idea is that, is that you have these accidents that occur for various reasons. So what you're trying to do is you're trying to set up all these little barriers so that for an accident to occur, it's got to basically go through all these different type of it's got to, get by all these different type of barriers. Okay. So that's the basics of quality. That's my little introduction to quality. Quality, if you go work in a hospital, it'll be a big deal. There'll be, every time I've gone to visit, to have a tour of a hospital, they always talk about quality. It's one of they have people who are, that's their job, is to basically be a quality manager. And that they'll go around and they'll talk about all the different quality initiatives that they have all throughout. And especially in hospitals, because hospitals are so complicated. But it's something that goes in through all healthcare, is that all healthcare kind of deals with quality. So, within our healthcare system, then, if you take a look and you think, well, where is it that our healthcare system tends to break down? If you have this episode of care, so we're not thinking about quality now in terms of how does Mercy make sure that they're they're not giving the wrong drugs to people, but how does our system kind of have good quality? Then the places that it breaks down are things like getting access to care, right? Having to be affordable, so that if there's a doctor available, is that it's affordable. Making sure that when they get into the system, the system provides good quality care. But then the other thing is, how do you go through and ensure that all these different types of providers work together? Because when we talk about episode of care, then remember we're talking about, like go get the ambulance, go to Mercy, go to Golden Valley, go to a rehab specialist, go to all these different type of providers. So one of the big questions within healthcare systems is, how do you ensure that everyone kind of works together on that? That's what's called integration or coordination of care. So when they talk about needing to know coordination of care, what they're talking about is they're talking about then, how do you go through and ensure that the system kind of works well? How do providers work together? And the goal then is that you're trying to get continuity of care. So continuity of care, in this case, what it refers to essentially, you can think about is that people, flowing through the system smoothly. So I'm not sure if anyone ever have tried to help someone get like a specialty care, like a appointment with a specialist, or like, let's say a common one. Someone goes to the hospital, they're going to get released from the hospital, and they're told, okay, you have to go to a specialist or to a rehab center. And so now you've got to try to figure out, well, how do I get to the rehab center, right? What am I going to do? And so it can be really complicated. It can be really, really complicated also if you're dealing with some type of health condition. So if someone suddenly is diagnosed with cancer, and now you've got to figure out, how do I get them into a cancer center? And then, what happens to the primary care? Will their primary care doctor know what the cancer center is doing? All these different types of questions kind of cut the rocks. All that refers to is basically how is care going to be coordinated? So if you take a step back and say, well, what is it that the system should look like? You can kind of think about that there are these different types of players. So let's say if I've got diabetes, just to name something at random, I've got diabetes, then how should the system work for me? Well, I should, there are certain things that I need to do at home, like eat healthy, or, make sure to monitor my blood sugar, make sure that if any type of issue arises, I know when to go to the doctor, et cetera. Then when I go to a primary care provider, they should know certain things, like they should know how to treat it. They should know I have diabetes. They should know how to treat it. They should, give me good quality care. There should be a funder who basically funds the type of care I need. And then if I have to go to the hospital, that the hospital should have good quality care, and the hospital should be able to find out what the primary care doctor did. Labs and pharmacies is that the labs and pharmacies have to be able to communicate, the results to the secondary and primary care doctors, et cetera. So it's a whole bunch of things. that then have to, for any episode of care, that you can kind of just sort of say, well, this is what each party should do in this case. So if one way to think about this then is just to start making a list and say, all right, so what do we assume? Well, for the individual, we assume that they know how to prevent basically diabetes from getting out of control. They know when they should go to the hospital, when they should go to the primary care doctor. They know kind of, what's appropriate, what's not appropriate. And that when they get some type of prescription, or they get some type of recommendations, that they should follow it. So primary care, they should know how to treat, they should know the history, etc. So you can go for each of the different types of groups, you could kind of start to identify, well, what is it that they should be doing, or that they should do? And also, what is it that we assume that people are going to be doing within the system? It's like, you think of this, it's like, okay, so here's the individual. Well, they have to get to a primary care provider. So whose responsibility is it to get this individual to a primary care provider? And for most things, do primary care providers, do they send out taxis for you? No, it's pretty much up to you to figure out how to get there. So there's an assumption here that individuals know that there's this primary care provider and that they can get there. They also assume that they can pay for it once they get there. Or they're going to assume that the primary care provider is going to give them treatment even if they can't pay for it. So there are certain basic things that are being assumed here about how the system works together. And that where those things start to break down, that's where you have problems. So this is the basic problem in our healthcare system. And it's the same in all healthcare systems, but it's particularly bad in ours, which is that everyone is silent. Right? All these different type of groups. This was the graph or little picture I showed you, I think, the first day of class. But it's and you see all these little lines between it that makes it look like, oh, everything's working together. But in reality, they're not working together. In reality, all these things are separate, and that very rarely does one group, one entity control all these different things. Instead, you've got doctors, primary care doctors, and you got hospitals. And the question is, how do doctors and hospitals work together? How does Golden Valley and Mercy work together? Okay, so the process then that you try to get these groups to work together, that's called integration of care. And so when if you go to a healthcare provider and they start, if you go work for the county, or if you go work for Mercy Hospital or someone, they'll talk about integration of care initiatives. And what they mean then is they basically mean, how do you get all these different groups, how do you get things to work together? Or from the patient standpoint, how do you get the patient to have to flow through the system smoothly? And it was a big push during the first years of the Affordable Care Act to have patient-centered care. So you'll still see that around, that there'll be people who talk about that they deliver patient-centered care. What patient-centered care means is that rather, you make the patient the focus of what kind of their healthcare experience is going to be, rather than the providers. And so when you evaluate them, the type of care that someone's going to get is that you sort of say, well, is this good for the patient? So let's take an example. Just did this big study on farm workers, right? So farm workers, vulnerable groups, that live in very rural areas, oftentimes have to go from job to job. They have types of jobs for which they can get injured, and if they get injured, they don't necessarily get paid. And so oftentimes they're very reluctant to kind of avoid, to go to the doctor, because going to the doctor means that they're going to miss work. So, and also going to the doctor, if they miss work, it can also mean is that the contractor or employer is not going to employ them again. So if you are Huia Delta Health Center down there in Tulare, and that you want to provide care to farm workers, what would you do? What could you do to provide care to them? Given those constraints, right? Given low transportation, not much money, can't really miss their job, or at least it's very, it's very hard for them to miss their job. And if they get injured and say that they're injured, and miss their job, is that they cannot, not be employed again. So if you're Quia Delta, what could you do? Well, let's see. With the standard, the type of model that they have, so here's Quia Delta. Here's Quia Delta in a big hospital with no fence that way. There's Quia Delta. Here are the farm workers out here. So what could, problem is they can't get there. So what could Quia Delta do? Yeah.
Bring the healthcare to them.
Yeah, bring the healthcare to them, right? So how do you bring the healthcare to them?
I've seen like where Kaiser, they specialize in like purchasing of us and they retrograde to like kind of start as a hospital.
Yeah, so that's an excellent example. So they do these mobile units, and so the mobile units then go out to the farms, and do growers want them to be there? Typically, yeah. Typically, well, it depends. Turns out that there's a difference between growers and contractors. So, some contractors is oftentimes when people work for a contractor, and then the contractor is the one who makes contracts with the growers. And so then, if you're employed by a contractor, that you might work on this farm this day, this farm the next day, etc. Where if you work for a grower, then you tend to work just for that grower. And so it may be a long period or a short period of time you work for them, but it's more stable. And so growers, especially the larger growers, they tend to do things like have mobile clinics come out. So they'll make a deal with Quia Delta that say, Quia Delta, you bring a mobile clinic out, and that then you can park it there by the side of the road. And then people can go there on their lunch hour, they can go there before work, or they can go there after work. Right. So that's one way to do it. So what's the problem that Quia Delta is overcoming by doing this? This is a type of integration of care, right? So what's the problem that Quia Delta is overcoming? Well, in like the way that we would normally think about healthcare is where would these people go to get care first? Where would people normally go to get care first? Through their primary care provider, right? Is Quia Delta a primary care provider? Well, no. Quia Delta is a hospital, right? They're a secondary care provider. But what Quia Delta is doing is that they're basically coming through, and that they are, acting as a primary care provider by going out there. Could Quia Delta partner with a primary care provider and do it? Yeah. So Quia Delta does. Quia Delta partners with some FQHCs in the region. And so therefore, they will have the van that go out there, they'll have training doctors and other people like that, but then they'll also have primary care doctors as well. And the primary care doctors then, if they find someone who doesn't have health insurance and has some type of medical condition, what they'll try and do is get them health insurance, and they'll try to then link them into the FQHC. So what they're doing is they're basically going out, this is a way of overcoming some of the barriers that exist, because the barriers are people can't get off work, and that they can't necessarily get to the clinics, and so basically the clinics are coming to them. So that's a type of integration of care. Another type of integration of care is that anyone ever been associated with a promotora? Have you heard about what a promotora is? Who's heard of what a promotora is? Well, promotoras are community workers, but they currently what they're being trained as is they're being trained to basically be care navigators. So what a care navigator does is that's somebody who will go out and will work with, who will be kind of work with people to help them navigate through the system. So this becomes really important if you've got, let's say if you've, if you've got some type of chronic condition and that you have to go see a specialist. And so if you're, if you don't have transportation and you have low English, and you now suddenly have to go through and deal with getting to a specialist, is that Quia Delta may not be able to the right thing for you or the right one for you to go to. And so therefore, what they do is that they assign you to a care navigator, and the care navigator then kind of goes through that they'll do the coordination for you. They'll go out there and try to help you coordinate through the system. So care navigators, another way of integration of care, right? Another thing, this was really popular a few years ago with in fact, they still do this for what they call high flyers. You ever heard of the term high flyers? High flyers mean people who are frequent users of healthcare. And so they're, I'll give you some more information about high flyers. But high flyers are basically people who use the healthcare system a lot, like every day they go in. And that in hospitals, then they cost hospitals tons of money. And so hospitals really want to try and reduce the high flyers, the frequent flyers. And so what they do is that they oftentimes will assign a case manager to the person. And so the case manager is someone who, what they'll do is that when someone comes in and is sort of someone who's got lots of chronic conditions, lots of health issues, etc., they'll go through and that they'll assign the case manager, and then the case manager is the one who's supposed to work with the person to try and make sure that they can get to the doctor, that they know when their appointments are. If they've got questions, that they can just talk to the case manager. They don't have to come down to the hospital. So these are all ways that what they're trying to do is they're trying to essentially find a way to integrate through the healthcare system. So with a case manager, what's the assumption? What's the basic assumption for why the system doesn't work well? Because this is the question asked. Whenever you look at some type of issue, problem in the healthcare system, right, where it's not working well, is that you have to kind of ask yourself, what's the basic assumption that I'm making about how things should work, and then how is it breaking down? So in this case, what's the basic assumption that's breaking down that means that I'm going to get a caseworker to fix? Person that is using the healthcare system inappropriately, doesn't know when to go to primary care, doesn't know when to go to secondary care, doesn't have any money to pay for, for transportation. So you can it's basically all on the patient in this case, right? There's all a patient type of problem. So the solution is get a case manager there, and then that case manager can go through and can help the person navigate through the system. That's a type of integration care. I had a graduate student a few years ago that was involved with, she was a nurse, and she was looking at the use of case managers in two communities, in a Maori community. So the way the Maori society is kind of organized in New Zealand is that it's all around maraes. So marae is kind of the community meeting house, but it's really the center of where most things in places where there's a large number of Maori, it's centered around the marae. So what they did is that they had case managers who were, Maori case managers who were worked with these clients who were, high needs type clients. And the idea was that they were going to help them through the system. And then they also had this group of what they call Pakeha, which are white case managers who were working with more kind of a rural white community. And so what they did then is that they would just compare, how well did they work? And they found that when they looked at the outcomes, is that the Maori case managers did much better than the Pakeha case managers. So why did they do much better? Well, when they looked at it, it was primarily because, with the white case managers, they were nurses. And so they saw their job as that they worked for the clinic, right? They worked for the doctors. And so therefore, what they saw their job was that they would call the patient up and say, you know that you have a an appointment tomorrow at, 2:30. And so, do you have a taxi to get here? If not, then they arrange them for a taxi, but that would be it, right? And so they saw that they were healthcare professionals, and so their jobs kind of ended at that point. Where the Maori case managers, what they did is that they saw that that they were community workers, and so if they called the person up and they'd say, well, you have an appointment at 2:00 tomorrow, can you make it? And if the person said, well, I don't know if I can make it because I don't have transportation, then they would arrange it. But if the person says, oh, I can't really, I have to go sort out my electric bill at that time, is that then they would help them sort out their electric bill. So what they were doing, the Maori case managers, was really being the bigger, kind of public health, dealing with these social determinants of health type thing. Whereas the white case managers were just feeling it more as kind of a, they were part of the healthcare provider, and they were employed by a healthcare provider, and that they were a healthcare professional, and they weren't going to help people sort out their electric bills. So that's so in each case, they were trying to integrate care in this case to overcome some of the barriers in the healthcare system. But the difference was that the barriers that the people were facing were not just kind of the standard type of thing, where it wasn't just knowledge, is that they needed a bunch of other things too to kind of make it work. And so that's what they did. So that's integration of care. They're using case managers. Another one is like the Merced Public Health has for years been pumping lots of money into trying to get Golden Valley to have the same information system as Mercy Hospital, right? Because Mercy Hospital has their information system, Golden Valley has their information system, and they're not the same information system. Why don't Mercy and Golden Valley have this, why don't their information systems kind of communicate with each other? Well, because when they made a big push back in the late 2009, 2010, to put all this money into getting information systems, to get electronic medical records, is that they didn't specify that, oh, everyone's got to use the same system. And so people use different systems. So you have partly a problem with just they're physically different systems that exist from all these different providers. That's one problem. But the other one is that Golden Valley may not want to share all their information with Mercy, and Mercy may not want to share all their information with Golden Valley. Why wouldn't they want to share information? Yeah, patient could, this is the sacred and the profane. The sacred is that patient confidentiality, they're protecting their patients. On the other hand, the other way is that, well, if Mercy lets out what everything happens to the patients it becomes more widely known, is that maybe people start seeing that Mercy screwed up, right, and did poor quality of care, and then they get sued or whatever it's going to be. So there has to be, because they're different organizations, it's not like they're going to just operate, they're going to just be kind of the same type of organization, and they're not going to cooperate with each other. And so the public health department, one of the things that they try to do is to get them to talk to each other. So what the public health department did is they put a lot of money into try to get go through and to get a information exchange, whereby they could send the information to this information exchange. The information exchange would then provide the information to the other group, but they would make sure that it was, it wasn't shared with anyone else, and that there were safeguards in terms of who could get it, but also is that the type of information that was shared was only the necessary information. So it wasn't like Mercy just opened up their computer systems to Golden Valley, and Golden Valley opened up their computer systems to Mercy. Instead, they had this little intermediate. So that's a type of integration of care, right? In this case, and the assumption being is that, well, the thing that's preventing good quality care is that there's not good information flowing. So we're going to provide information flowing. But ultimately, these things are very difficult to kind of do, because you're doing it very piecemeal. You're saying, oh, we'll get case managers. Oh, we'll get information systems. Oh, we're going to get, and so you can do it at this very, very kind of bitsy type of level. And it's like playing whack-a-mole. And that every time that you think that you've got some type of thing, problem fixed, something else pops up. So the other way to do it is that you essentially put all the organizations together. So you have the hospital, and you have the primary care, and you have the labs, and you have everyone all owned by under the same entity. And that entity then, they're the ones who make sure that there's information flowing and everything else. Do we have something like that in California, where there's one group that owns the hospitals and the primary care sites and the laboratories and everything else? Who does that in California? Yeah, Kaiser, right? Or the VA. VA does it too, but that's Kaiser. So what makes Kaiser so unique is that they are what's called a vertically integrated system, because they have all these different types of specialists in primary care and hospitals, and everything is under one organization. So they don't have to worry about information sharing. They also don't have to worry about things like, one group passing off the patients to another group. For example, like if someone comes into Mercy Hospital and who's a frequent flyer, and Mercy doesn't want to deal with them anymore, is that Mercy can just tries to get them to go to Golden Valley, but Golden Valley may not, be necessarily jumping up to give them care. So, if you're all under one organization, then you don't have to worry about it. So that's why, oftentimes when we talk about what type of healthcare provider system should we have, people point to Kaiser, because you say, oh, look at, Kaiser has everything under one umbrella. It's an integrated system. They don't have to worry about if problems arise, is that you've got someone who's responsible for dealing with it. The problem in our system, outside of Kaiser, is that whose responsibility is it to take care of a patient who, can't get to all the, who can't flow through like that? I mean, really, whose responsibility is it? If you think about people who are homeless, whose responsibility is it, Merced, to get them healthcare? I mean, the county kind of takes up that role, but the county is not really a healthcare provider. So they could try to get people who are homeless. They can try and get them care. The government, the governor's office now, it has this big push to try and get homeless off the streets. And so the governor's office is kind of taking it over and trying to do things. But the problem is that, there's no one kind of here in Merced who that's their responsibility. So that's why when we talk about problems in the healthcare system, what we're really talking about, like in this type of way, is we're talking about lack of integration. And lack of integration occurs because no one's responsible for it. There's no one out there whose responsibility it is to make sure that someone's homeless gets healthcare. On the other hand, if that person was a Kaiser patient, then Kaiser has a responsibility to do it. They may not do it poorly, but they still have that responsibility. All right. Okay, well, I will stop there because we'll on Thursday, then I think that's probably all I'm going to talk about in terms of integration of care. But on Thursday, we'll switch topics and move on to probably talking about becoming a doctor.